Well, hello, and welcome to Region 7 Podcasts, where we conduct interviews with our Region 7 colleagues to learn the perils and pearls related to our COVID-19 response in the hopes of sharing lessons learned and learning something new that we can all benefit from. Today, we're going to talk with David Brett Major on the hot topic of COVID-19 vaccination. So without further ado, please welcome Dr. David Brett Major. Hi, David. Is it okay if I call you David?
Yeah, of course.
Okay. You can call me Kate. Welcome. So I was just thinking it might be a nice idea to have you begin by telling our listeners a little bit about yourself and the work that you've been doing throughout this pandemic.
Sure. So I'm David Brett Major. I'm a faculty member in the Department of Epidemiology in the College of Public Health here at UNMC in Omaha. And I also work with Nebraska Medicine on the Infectious Diseases Consultation Service. I'm a clinician, and quite a bit with our Global Center for Health Security. And so during the pandemic, I've been among the many healthcare workers here who've just had varied roles as the needs demanded it since the pandemic started. We launched a cohort study, a prospective observational cohort on COVID-19, and have a niche, a small but well-curated cohort that's helped a couple of federally partnered developers work towards medical countermeasures. And I've participated in the way that the institution thinks and plans about research and emergencies during the pandemic, as well as the small steps that everybody does throughout the region to make sure their institution is doing the needful to be able to be ready or execute COVID care or messaging to the community, but mostly in a supporting role. Many of the colleagues that, like Kate and others who are more in front with all of those mechanisms, lead that.
Yeah, I wouldn't sell yourself short, David. I know you're a very busy man, and I am so grateful that you're taking this time to have this conversation with us. So we're going to try and stick to the topic of vaccination because that's something that's on everybody's minds at this time. So as we tape this interview, it's November 11th, it's Veterans Day, and 2 days ago we actually got the good news that Pfizer, when they announced that they have a vaccine that will be available soon. So what are your thoughts on that? Is there going to be more vaccines that are going to be in development, and will they be available soon as well?
So there's a lot in those questions. Pfizer did articulate good news. They said that on an early look of the progress in their about 43,500 participant study in multiple places, not just the US, but many international sites, that they had something like 124 COVID cases, and that the vaccine conferred about 90% efficacy in prevention. If you received the vaccine on day 0 and day 21, and we did not look for COVID for another week. So once you were a month out from starting the 2-shot process, it looked like it conferred protection at about a rate of 90%. So what to do with this information? Yeah, it's a moment to stop and think about it, even if you're in the vaccine development space. The early look was a scheduled look to assess, like in any phase 3 clinical trial, whether the study should continue. So the purpose of the look is not to ask or understand if the Pfizer vaccine is fantastic and should be made a lot and given out to people. That's actually not the purpose of that look. The purpose of that look is there sufficient evidence present already in the study that the vaccine has met its analytic endpoint, which was a reduction in COVID-19 cases validated by testing. And if it has not, is it likely to be able to tell you an answer by the end of the study? So it's really a, oh my goodness, is there a concerning safety signal? Or, oh my goodness, is it so fantastic that it should stop right now because we already know the answer? But really, does it make sense to spend the massive amounts of resources on a 43,500 person phase 3 international clinical trial because we might still continue to get useful information? That's really what the look is. So it's good news. It's great that they saw a signal. It's early days. It's only 120 cases among the 43,500. And we'll just have to see. When they looked at it, they said the trial should continue. We'll see where the data goes. But it's very good news for a few different reasons. One reason is that the vaccine is a messenger RNA vaccine, and it would represent the first potential, if successful and ultimately shown safe and effective, it would represent the first licensure in human use in that class in the US. So that's exciting. This is a new technology. It's been worked on for a while in areas in tropical public health. I have friends who've been working on this in tropical medicine diseases, and it's sort of crossed over into the emerging disease space because you can make it quickly, and that's great news. Another piece of good news is that the trial size is so large that 120 cases actually represents a little bit more than 200 per 100,000 cases. So we actually have communities in the Great Plains that are experiencing COVID-19 case rates at the exact same burden and higher, frankly, than this study. And so if the data carries through, some of these communities in our region that are currently the highest incident places in the US, if they were to experience a safe and effective vaccine after a few incubation cycles of the disease, they would then be potentially among the lowest incident places in the US with the vaccine in concert with, because everyone is asked to affirm that they will do in a vaccine trial, physical and social distancing, masks, hand and environmental hygiene, mindfulness of when you're sick and of aggregate settings, right? The usual things. So it is good news, but there's a lot more to be learned. We could be surprised. When the recombinant vesicular stomatitis virus vaccine developed by Merck for Ebola virus was developed, EBO, initially, proponents of that vaccine in a trial that wasn't actually much smaller than this one asserted actually perfect performance with a similar caveat on when after vaccination you might have been exposed. And then they adjusted that to about 90%. And then eventually, as the data in multiple locations came out, its efficacy is about 70%, maybe a little bit lower than that. It looked initially like a fantastic vaccine. In reality, it's a very, very good vaccine. And so we may see that with the Pfizer product. I'm optimistic. There's more to talk about with that, and I can go on that way, but I didn't know if you wanted to redirect the conversation.
No, that's whatever you feel like you need to tell us about it is what we want to hear. There is a lot of excitement, or there seems to be a lot of excitement, especially in the media, around this 90% effectiveness. And just hearing what you were saying when we compare it with the Ebola vaccine, but what about, for the layperson like myself, that this is all very complicated. How does it compare with like the flu vaccine? I mean, what sort of effectiveness do we get with our annual flu?
So the real reason that we give the influenza vaccine is to decrease total population load of influenza. And if you're in a particularly high-risk group, to decrease severe outcomes in you. But in general, it's not a vaccine to make sure that nobody gets flu as an individual. The efficacy of flu vaccine is between 30 and 60%. That varies depending upon the match each year between the guessing that the committee does on the mix of strains represented in the annual flu vaccine from what they experience. And every once in a while, when there's a bad match, you still get something like 1 in 3 effect. And if there's a very good match, you get something like 2 out of 3 effect. There are real problems with the flu vaccine. The influenza vaccine is very important to how we manage public health. Influenza is still a major killer, both with direct death and as well as indirect death, meaning I have heart disease and I have my heart attack now because of stress from the influenza, and I get counted as a heart attack. Influenza is a huge deal. Months before this pandemic, in late 2019, NIH announced its principal initiative for the coming year, and it was the universal flu vaccine. So influenza is still a huge deal. There's absolutely a recognized need for a better influenza vaccine. If this performance bears out with better, the data, I'm sure their data is good, but with more data, more of experience on this Pfizer product, if it beats 1 and 2, if it beats 50% reliably, it's doing better than the flu vaccine, and the flu vaccine is important. The flu vaccine is important also in the context of social and physical distancing, mask use, hand and environmental hygiene, and mindfulness of when you're sick or others are in a aggregate settings. That's true in flu season too. And so all these things are predicated on that. So for another frame of reference that might be helpful is the measles vaccine. So with the measles vaccine, that's a really well-performing vaccine. And greater than 9 out of 10 people have pretty demonstrable, probably protective immunity. Surrogates of immunity are a really tricky thing in vaccinology, but it's a very good vaccine. There's a reason we get it. Everybody should get a measles vaccine. If you have a room and your room has 10 people and they've all been vaccinated and you want them vaccinated for measles, you need about 9 out of 10, if not all of them, vaccinated for measles if someone with measles walks in the room to prevent an outbreak. You need really high vaccine uptake. So even when you are in settings where the vaccine is good, if it's a safe and effective vaccine, it has to have good uptake. People have to use it. And it has to be used in the right setting, which is exposure in general is mitigated, which means physical and social distancing, masks, hand and environmental hygiene, mindfulness of when you're ill, when others may be ill in an aggregate setting. So that stuff never changes. You need that even with what we would consider the best performing vaccine.
Okay, this is something I was going to get into later was, so if we get the vaccine, would that mean that we no longer need to wear a mask or do our social distancing? So I'm hearing that's going to continue for quite a while.
Yeah, you need to get the background rates low enough so the vaccine can do its work. So if we were smart, what we would do is get super aggressive on physical and social distancing, mask use, hand and environmental hygiene, and being mindful when we're ill or others may be in aggregate settings. We do that now so that the background rate was low enough that when the vaccine was available as an additional layer, it really knocked down the total risk of what's around you. Everybody reacts differently to vaccines. Everyone has variable levels of protection, and even the best immunologic protection has its limit. So you had asked the question earlier about whether or not other vaccines should come to market. So should I talk about that a bit?
Yes, please.
Yeah, so there was an interesting paragraph in the Pfizer release that said that they thought that they were going to be able to produce 50 million doses in 2020 and 1.3 billion doses in 2021. That's quite an achievement, but I think we should put that in perspective for a moment. First of all, 1.3 is not 7, right? Yeah. And so broad global distribution of vaccine, and this product is a globally generated product, globally tested, it will be globally distributed. has a high burden and demand in many places. And so it's fantastic that they're able to scale up at that level. You mentioned the influenza vaccine earlier. Only about half of people in the United States get the influenza vaccine each year. So that's about 150, 160 million doses. So just talking about the US, with a need of about 200, 250, assume that there are going to be some exclusions, but with the need of a couple 100 million doses, every year with a flu vaccine on an infrastructure that took decades to develop, we don't do that. We don't produce and distribute that much flu vaccine. We are trying to do it with coronavirus vaccines, and it's a big scale up. It's one of the reasons why multiple vaccines in the marketplace probably is a good thing, because they may, if intelligently selected, once they've each been demonstrated safe and effective, they'll use different reagents, different factories for generation, maybe have different requirements for logistics in terms of cold chain that change for its use for areas that might not be able to support particular logistics, and also may have a different immunogenicity profile with different people. Maybe there's one product that works really, really well if you're less than 2, and another product that works really, really well if you're at a high-risk age group. And so, that's something to think about. Those are all reasons to have multiple vaccines come up and through. Now that said, MMR has great uptake, but everyone does not need MMR at the same moment.
I see. So with all of this in mind and the excitement that, we are going to be getting a vaccine, I think the thought on a lot of people's minds right now is it safe? You did mention, not everybody will get this vaccine. But how can we convince people that it's safe enough? So what are these companies doing to ensure that safety?
Well, the companies are going through their usual product development requirements with the Food and Drug Administration and the other regulatory agencies involved, and they will have to disclose that to the agencies. They also have to disclose it to internally for their own risk management. Companies do not want to produce and distribute a vaccine that's going to be a problem for them. It is not in their interest. And so frankly, I think the business case for the US is really, life is better with a safe and effective vaccine that can be produced and distributed, and to which people will accept over time, potentially, because we don't know what will happen once we are able to intervene on this pandemic. We don't know anything about the cyclical nature that might occur subsequently. H1N1 from the pandemic in 2009-10, we saw that for several years, actually, later. This may be the case with SARS-CoV-2 and COVID-19. So I think they're doing the usual things. Communicating confidence, in my mind, is a matter of taking the usual steps, being transparent, allowing peer review. Yeah. And if they do that, and the vaccine is indeed safe and effective, I think there are ways to promote vaccine uptake. But we have to start with the truth. And the truth right now on the first look is good for this product. And that's fantastic news. And hopefully that will continue to be the case as the data set increases in size, and that's analyzed and looked at carefully for the best age groups for utility and value in terms of a health outcome and community outcome value from application, the prioritization issues, and that all moves forward. But the narrative has to start with what the results are. And really the only thing we know is looks good, which is great. They should have told us, and it's great that they did. There's just more to learn.
Yeah, with all the attention on the vaccine development, I don't think we've ever been so up and close with any vaccine in the past, where we know when there's pauses and stops and, things like that. So yeah, I'm hoping that, I'm pretty sure we can put a lot of trust in this vaccine. Um, and any initial thoughts on, do you feel like this is going to be like the flu vaccine where we'll have to get boosters every year? Or do you think this will be a one-time dose or a two-dose vaccine, isn't it?
We really do not know. So
Okay.
it will depend by the vaccine, and it will depend on longer term assessments of immuno duration. And I think it's all guessing now. We really just have to see the results. When we made these guesses about the recombinant vesicular stomatitis virus, the RVSV EBO, we were expecting much shorter dwell times of immunoprotection and of immunologic response in the assays, in the tests, and it lasted longer, much longer than the 3 to 6 months we kind of thought initially. And so it went from being just really an emergency interruptive product to, well, maybe near-term protection for an event. So we'll just have to see. You have to observe and see what it tells you.
Okay. So with this vaccine hopefully coming out in December, January, it's about the same time of the year that a lot of people are getting the flu vaccine. So is this something that you think would be safe to get together? Can I get the flu vaccine and then get the COVID vaccine all in the same day, or should they be separated?
So I once gave a patient who was about to travel internationally a rabies vaccine, a typhoid vaccine, and one other in the same day. And he happened to be a good friend of mine, and it strained our relationship. So it is true that when you get multiple vaccines, as any parent knows, it can be a lot, right? And sometimes you say, oh, you know what, I'll come back next month for that one. That said, I do not know yet the reactogenicity profile. Reactogenicity refers to immunogenicity is if I give you the vaccine, is your body now going to be able to protect you at least a bit from the threat? That's immunogenicity. Reactogenicity is if I give you a vaccine, is your body mad at you for having taken the vaccine? Yeah, is your arm sore? Do you have a fever? That's all reactogenicity on the scores. I know most of you know that, but we don't know really the full reactogenicity profile yet in those details. My suspicion is that it'll be fine, that you could do. Actually, it may even be advantageous to do them together. I don't know, and I don't think we will know until we get some more data, but I think that's okay. But I also think it's probably premature. We were already talking a few minutes ago that they're only making use in 2020. And then across the entire year, they'll make enough doses for 1/7 of the population of the planet. And so I don't think anybody should have any new expectations about a vaccine being available to them right now. And it will be interesting to see if it gets far enough. I mean, it would be great to see if it gets far enough for limited distribution under an emergency use authorization, if it happens to be safe and effective at the next few looks. And it would be great to see that distributed for particularly vulnerable or high-risk settings. So maybe a few people who watch this podcast might see it. But in terms of broader population use and messaging, we're still several months away from talking about this or any other COVID-19 product being available for public consideration of overlap.
Okay, so I probably know the answer to this already. So one of the good things that people could probably do right now is get the flu vaccine. Get it now. Get it up ahead of the game, and maybe help deal with that. When we get any vaccine, David, what should we as a public or even healthcare workers be asking before we get it? Is there something that I need to know specifically? And then be able to help me make that decision that I'm going to get that vaccine?
I think usual medical informed consent is what we should all seek. And we should not shortcut that in an emergency. It does not have to be burdensome, but it should be present. When I get a flu vaccine, I get a whole page. And that page tells me for who the vaccine is indicated, what is known about what it does for good, what is known about what it does for ill, and what I'm likely to experience when I get it. And it checks whether or not I have any of the contraindications. And I think we should expect to see that same kind of deliberate risk communication around the product when we go and seek the vaccine. And I'm sure that will be present, but you're right to say it out loud and to ask people to look for it, because in some settings there could be a rush to get vaccine uptake and use. But I suspect, usually under emergency use authorization mechanisms, there's a very specific risk communication sheet that goes with it, so that folks have some awareness of the fact that it's not fully licensed. The vaccines will come out not fully licensed. They'll probably be under an EUA, which means that the risk-benefit analysis says we should go ahead and use it, but we're going to keep looking. As it happens with the licensed vaccine, we sometimes take our backsies as well. The rotavirus vaccine, the old one, was a good example of that, right? That was pulled off the market for intussusception. So it does happen. And so there is monitoring that happens for vaccines in the marketplace already, and it's gotten very good over the last several years. And it's going to be under even more scrutiny under an EUA. So I think that's good. That's positive that that's the case. And so, if the data is appropriate and it moves through peer review appropriately and the agency reflects on it appropriately, then we should embrace the countermeasure.
Okay. If I had been one of the people that had gotten COVID, would I still need to get the vaccine?
Well, we know reinfection happens. We're still a little unclear on how frequently it happens, but we know it happens. I think the studies will probably have people who were infected. I think that they probably will understand the pre-enrollment infection rate better later on in the study, because people might not have histories and the assays get better, the antibody assays get better. And so we'll see. That's a long way around saying we'll see. I think there is probably a role for vaccination regardless. We do not get the flu vaccine because we happened to have flu, even if we happened to have flu with that particular strain. And it's still something that we do. So that will have to be observed.
Okay. And am I right in thinking right now that it's not going to be available for children? It's going to be a while.
Actually, I think they're talking about pediatric trials, and we'll just see. And the definition of children changes in every place. So the age of majority in Nebraska is 19. I suspect if you're 19, you can probably get this vaccine. If you're, in fact, if you're 16, right? So it'll be interesting to see how that is discerned when they do the emergency use authorization, should it reach that point. And also, I think you're going to see more and more people talking about pediatric vaccine studies now that these other studies are starting to hit their initial looks. Nobody wanted to do the pediatric vaccine trials until they had an initial safety signal in the adult phase 3 larger trials. Well, those trials are now starting to hit those points, and so I think you'll see more pediatric vaccine studies.
That's good. Well, David, again, I can't thank you enough for sharing your knowledge. Also can't thank you enough for doing everything that you do. I do feel like one day we will be able to get back to our normal lives. Sort of hoping that vaccine is going to be the key to that. But is there anything at all that, I haven't asked you, that you feel that you want to tell the world about vaccine.
Yes, my most important message about the vaccine is we should all be paying attention to physical and social distancing, masks, hand and environmental hygiene, being mindfulness when you're ill and others are, and being careful about of aggregate settings. That's my vaccine message.
And hand hygiene, yes, I think that is just perfect. Okay, well, I really did enjoy this conversation. And as I say, I hope our listeners have found something of value that they can take from it. And again, David, we just thank you so much for your time today. Very, very much appreciated. And, you know, we are really fortunate to have you move into our region. Thank you. Bye. Bye. Thank you, David. So for all of our listeners in region, I'd just like to point out that each of our state public health departments have a plan. They already have it posted on their public health websites, and we are posting those links, as you can see here. I would say keep watching them. They are living, breathing documents that will update as new information comes around. So I will thank you, and would really love to hear from you. If you know anyone that you would like to hear a conversation with, or if there's a topic that you'd like to hear a conversation on, or if you have questions that we can help you find the answers, please send your ideas or your thoughts to nbu@nebraskamed.com. And again, I will just say thank you for listening. Goodbye.